Welcome, everybody. We are joined today by Mallory Litt, and her credentials are BSN, MSN, ANPC, and then she is an oncology nurse practitioner. Mallory is going to be talking today about understanding imaging for gynecologic cancer. Mallory is a nurse practitioner and has been with the GYN oncology team since 2017. She sees patients with Dr. Valentin Kolev and became the GYN oncology clinical program manager in 2022. She hopes this talk can provide basic understanding of the certain imaging tests your doctor may order, why they're important, and how the results may impact your surgery and/or treatment. Mallory, thank you so much for joining us today. I'm going to mute myself.
Thanks again for having me. Hi, everybody. All right, so I'm going to share my screen. All right, so imaging review, why are certain scans ordered? This is me, my name is Mallory. Again, I am a nurse practitioner here at the Chelsea Center. I work primarily with Dr. Kolev, but I help cover all the other practices. I've been a NP here since 2017, and I obviously really enjoy working in gynec. So let's get started. Okay, so why do we order imaging? We most commonly order imaging for a couple of reasons. The first being a diagnostic workup. So typically, you may present to your doctor with a certain complaint. They may order blood work, and in part with that, they may order some type of imaging to get to a diagnosis. What's going on? What's the issue? You may have imaging ordered as a baseline scan or staging prior to starting a treatment. Treatment being chemotherapy, immunotherapy, or surgery. So oftentimes, you may see your PCP because of a complaint. They order some stage, or they order imaging. They may order like an ultrasound. They find something abnormal. They send you to an oncologist or a GYN oncology doctor. They order something like a CT scan, which will, get a more clear picture. And based on that scan, they may decide, you have a suspicious mass or you have something abnormal. We need to proceed with surgery, or do a biopsy, get a confirmation, and start with chemotherapy. We also order imaging to assess for treatment response, surveillance. We may order it because you've completed your treatment and now you have a new complaint, and we want to just check on things and make sure, see where we are. And we may order imaging for restaging. So say, unfortunately, your cancer came back, we need to restage it and see where we're at. So the first, I kind of want to go from most basic to most complex. The first modality I would say that we order for certain issues is a transvaginal ultrasound. You may see it abbreviated in your notes or orders as a TVUS, and this uses sound waves to produce images. If something is solid in the pelvis, the sound waves bounce off of it. So you may see the terms echogenic in your report. That usually is not normal. Like the sound waves are echoing off the solid component to a mass or to something on the ovary or to something within the uterus. And the transvaginal ultrasound uses the probe that I have in the second photo to help image pelvic organs. Those organs include the ovaries, fallopian tubes, the uterus, and cervix. If you can't tolerate the probe, your doctor may just order a pelvic ultrasound, not a transvaginal ultrasound, but a pelvic ultrasound, which just uses a regular ultrasound probe on the top of your lower abdomen or your pelvis. It can sometimes be a little bit more limited, but for patients that are virginal or patients that can't tolerate the probe, it's our only option. And sometimes this is the first method that we use in a diagnostic workup. Specifically, some things would be postmenopausal bleeding, bloating, pelvic or ovarian mass, or a fibroid. So Sometimes we'll see patients coming in for a consult because they had postmenopausal bleeding. They went to their GYN doctor who ordered them a pelvic ultrasound. And you can see here, this is a picture of the uterus. The ultrasound will look to see how thick the lining is. And if they have a thickened lining and bleeding, then we know that there needs to be further workup with a biopsy or hysteroscopy DNC. So oftentimes an ultrasound, it might be ordered once a year just to check in by your regular GYN doctor, or because there's something going on and it's our first step in this diagnostic workup that we're doing. Not always the only test that we use. Like I said, sometimes we need a pathology like a biopsy or a DNC done to diagnose something, but it's oftentimes the first step because there's no radiation, there's no contrast, they're safe, and they're relatively, I think they're relatively, I use the term relative very loosely, but they're cheaper than some of the other exams. Like I said, no radiation or contrast is needed, but sometimes a full bladder can be helpful. And usually when you're scheduled for an exam like this or a CT scan, the radiology team will call you in advance and tell you what's needed on your end. We often use transvaginal ultrasounds in combination with the CA-125 for BRCA monitoring. So if you have a BRCA 1 or 2 mutation, you haven't had surgery, you're of childbearing age, and we're just keeping tabs on you, then we will order one of these every 6 months to 1 year. Any questions about transvaginal ultrasound? All right, moving along. CT scan. So CT stands for computerized tomography, and we use this most commonly for surgical planning, staging, recurrence or restaging, or a diagnostic workup. And the reason why we use CT scans primarily for these reasons is because they do a pretty good job of showing calcifications or solid-like masses. You can see here in this photo that there are very well-defined borders here. So we're looking at the liver. You can see there's very well kind of approximated edges here. When there's an abnormal lesion or mass, it often gives us really good boundaries that we can see, and your physician can determine if that mass there is surgically resectable. We often order the CT scan with a chest, abdomen, and pelvis when we're doing it for staging, so that we can see all parts of the body from the chest downward. The CT scans that we need most often do contain IV contrast, which uses like an iodine derivative. And some patients may be allergic to this. And when that happens, we have to pre-medicate you with oral steroids and Benadryl. Sometimes there can be a cross-reactivity if you're allergic to shellfish or aspirin. So your nursing team, your clinical team, and your radiology team will always confirm that with you prior to getting the scan. And we'll make sure that those pre-medications are ordered. Another thing about CT scans are that fasting is often required, and CT scans can expose you to ionizing radiation. So it's one of those things where we really have to outweigh the risks and benefits. If you're going through a diagnostic workup and you need the scan before surgery, you need it as part of your chemotherapy or immunotherapy kind of regimen, or if you're on a trial, then it's something that's definitely needed. But say, you've been 5 years out of your treatment and your risk of recurrence is very low and you're feeling fine. You don't have any current symptoms, but you want to scan for peace of mind. That's something to consider because you are exposed to radiation with every scan that you get. And that's a conversation I like to have with patients when I feel like sometimes the scan is unnecessary, but they're really, really pushing for it. So that's something to consider. Any questions about CT scans?
I do.
Oh, go ahead.
Yes.
Go ahead.
When I was done with my chemo, but going in for that first year or two,
Mm-hmm.
I would get CT scans, and initially the doctor was requiring them or requesting them,
Mm-hmm.
and then when she didn't, I asked for it, again for peace of mind. I guess the question, you've kind of already answered it. Like, how do you kind of balance when a patient is, anxious and your clinical?
That's a great question. Ultimately, the way I see it is ultimately like we have to give you all the information, and the decision is something that you make in partnership with your doctor. Part of it's also insurance too. So is insurance going to approve a CT scan if you, and I'm just saying this is like just a very vague example. If you had a very low risk endometrial cancer 6 years ago and you want like a scan for peace of mind, your insurance company may not approve it without, in the absence of any symptoms. Typically, the farther out you are from your treatment, the lower your risk of recurrence is. Now, that is just a very broad, very loose statement here. And I know a lot of you have had unique experiences that don't correlate with that. But typically, the farther out that you get from your treatment, the less concerned we are that you may have a recurrence. And so those first 1 to 2 years, we keep a very close eye on you all. After that, you can start to give a little bit more leeway. And again, that's not to say that things don't happen. The second that you have a new issue or something just doesn't seem right, then we would, order a scan and bring you in as soon as possible.
Mm-hmm. Okay.
The other thing I forgot to mention is that the CT scan, when we use contrast, you have to make sure that your kidneys are functioning. We can't order CT scans for patients who have really severe kidney issues or are on dialysis. If your kidneys are, kind of like, they're not great, but they can, your creatinine level's a little elevated, we can always give you like fluid or something after the CT scan to kind of flush the contrast out of your system. But sometimes we need to do blood work before CT scans to make sure that your kidneys are okay. That was one thing I meant to mention.
Marlene, your hand is up.
Yeah, I want, you sort of touched on some of this, but I want to be clear. Right now, for example, if someone is finishing up treatment for gynecological cancer, let's say cervical cancer, what are the current recommendations in terms of having a CT for a follow-up? Is it every year for a certain number of years, or can you address that issue?
These would be all NCCN. They're typically NCCN guideline directions. So it depends on how aggressive your cancer was. And some of the guidelines are very vague. Some say PET scan, some will say CT scan. So a lot of it is also individualized too. So say you have cervical cancer and you had a CT scan as part of your workup, and then we got a PET scan, and the PET scan showed some kind of questionable lymph nodes, and you had a really, really kind of rare, more aggressive form of cervical cancer, not just the basic squamous cell carcinoma that we most commonly see. Your doctor may be more inclined to order you a CT scan, or I'm sorry, a PET scan once every, 3 to 6 months versus once every 6 months to a year, which may be recommended by the guidelines that we use. And when that's the case, your clinical team has to be very upfront with your insurance company and make sure it's all documented so we can get it approved by your insurance.
But how long after
Sometimes that,
I'm sorry, go ahead.
No, go ahead.
No, I was going to say, but how long, for example, after you have finished treatment, would you need to do this, the PET or the CT? Because for several years after I was in treatment, every year I had to have a PET/CT. And, I'm just trying to find out, what, the sort of standards are, because there was not a lot of communication about timing and all of that sort of thing. So I'm just trying to understand, you have explained that it's, situational and your individual case, and I don't know, by the way, what does NCCN stand for?
So NCCN, it's the National Coalition of Cancer Network. I think that's what the exact.
Oh, okay. Thank you.
It's basically our governing body in oncology. It sets all the standards, all the guidelines. But a lot of the times when it comes to imaging, they can be very vague. And so again, like say you have cervical cancer and your vagina kind of it adhered to itself after you completed radiation, and we can't really do a good exam on you in the office. Your doctor may be more inclined to order a CT scan, more often than what a standard might be for your case. So it might be more than every 6 months to a year. I'd have to pull the actual guideline up to see what they say. But they don't always give time frames. It's more so consider an MRI or consider a PET scan in this part of the workup or this part of the, I guess, surveillance. They can be pretty loose, unfortunately. Unfortunately, but for us, when I'm looking at those guidelines, I'm usually doing it because of insurance issues. Your insurance doesn't want to approve the scan, and I need to, discuss with them why it's so important. And if that's not documented in your notes for whatever reason, or if you don't have any symptoms, or if the NCCN guidelines don't support it or give very vague terms, then I can't always get it approved. So there's a lot to it. I probably just gave you information overload, but it's very individualized and it's very dependent on your physician. And the farther you are away from, your initial date of diagnosis and when you finish treatment, the less likely you are to need, those serial exams once every 6 months, once every year.
Okay,
we start to loosen the reins a little bit.
Thank you. That was very helpful. Thank you. One question about risk. Is there a difference in the risk factor between a CT scan with contrast and one without contrast?
So the one without contrast still has a little bit of radiation. So like if we're looking at your lungs, I believe it's not nearly as much radiation without the contrast, but it's still that picture. That picture is exposing you to some.
Yeah, I bring it up because I've had to have lots of CT scans not related to the gynecological cancer, but to issues with my gastrointestinal system. And every time I've had to go to the ER or whatever, and I'm having, some sort of problem with my stomach, I'm getting a CT scan. I've lost track of how many I've had, but that's why I was trying to just understand the difference. Okay, thank you so much. That was very helpful. Thank you.
Of course. All right. Any other questions?
There's 2 hands up. Nancy, I think you were first, and then Glenn, you were after. So Nancy, you go ahead. Nancy, if Nancy's there, or Glenn, you go ahead.
Next is coming to like 1:30, so I'll wait.
Oh, I'm sorry. I didn't unmute. I'm sorry.
Oh, okay. Hi. No, go ahead.
Hi, how you doing? No, my question was, can a CT scan be wrong or incorrect or not have the right information? Or is it that the radiologist read it wrong?
That's a great question. So you actually beat me to one of my later points in the talk. But it's very important that your doctor actually reviews the images themselves, because the report is going to be generated by a radiologist. There are some new AI techniques that are coming out where AI will read the report and it'll be notated in the report. But it's really important that your doctor actually looks at the images themselves. If you all were new patients to our clinic at one point, we may have requested that you bring your DIF or bring your CDs to your appointment, so that our physicians can actually look at the images themselves, and then they can agree or disagree with whatever the radiologist read is. So there certainly can be some, degree of error in a radiologist report. But the images are images. And the reason why, we need you to have sometimes like a full bladder or fast, or, have you get contrast, is so that we can get the most out of these images as possible, for an accurate read. But yeah,
So
it's always
now-
important that the doctor and all of our doctors read their own images.
And okay, so if you have a CT scan that's done and they feel that it's not, up to speed, and then they make you do an MRI, and then the MRI comes back and it says something that's different. How do you, as a patient, how do you feel comfortable? I mean,
So the CTs and MRIs, you may need both. And that's not necessarily because one image is better than another. CTs, like I said, are really good at defining like borders of masses and solid objects. MRIs, as you'll see, are better looking at tissue. So it might be that you had a CT scan, but now they need an MRI to get a better characterization of something else that was found on the CT that was incompletely viewed. MRI can give a better look at like soft tissue, like organs and parts of your body. So as you'll see in the next slide, if we're looking like inside the uterus, or we're looking in the brain, or we're looking in the spinal cord, sometimes MRIs are actually better because of the definition that they give to the soft tissue. So you may need multiple different types of imaging modalities because we're looking at a couple different things.
okay, thank you.
Any other questions?
Yes. I
Yeah,
had a-
go ahead.
Yes.
Hello?
Hello. Um, I'm gonna ask the question. I wanted to ask a question.
Sure.
Go ahead. My question is, can you hear me? Do certain hospitals prefer CAT scans to PET scans? Because when I was first treated at Memorial, they used only CAT scans. And then when I went to Mount Sinai, they used only PETs. They used only PET scans. And last summer, I had alveolar cancer, and I had a CAT scan at Memorial, and the CAT scan didn't show anything amiss. But the PET scan they took at Weill Cornell showed that I had alveolar cancer. So how is that explained?
So if we know that there's something on a PET scan that typically we don't see on CT scans, then your doctor should continue to follow you with a PET scan if that's what they're looking at.
Oh yeah, but how come it didn't show on the CAT scan?
So sometimes we order CAT scans with PET scans to get more imaging. Part of your diagnostic workup, you might need a PET scan with a CT scan so that we can get the two different pictures and correlate them together. And then at some point they may just follow you with a PET scan. But like you said, there may be something on a CT scan that doesn't light up, and then you get injected with the PET scan contrast, and something becomes FDG avid that wasn't seen then on the CT scan. So I don't know if maybe something changed in your course of treatment where you had something new on a PET scan and that required you then to be followed with a PET scan. But it's typically not hospital to hospital. I would say it's more so how is your physician following your cancer.
Okay, thank you.
Mallory, I
Mhm.
apologize. My internet like knocked out for a minute. I know there have been a lot of questions about CT scans. And I know that you do have the other type of imaging part of your presentation. Would it be, do you want to move on a little bit to see if what the questions that people are asking are part of your presentation already?
Sure. We can move on. Did anybody have any other questions about CT
Yeah,
scans specifically?
Yeah, I have a really important question, I think. You mentioned very briefly that now images are read by AI. How long has this been going on? And
They
how
can be. Well, you'll see it. So all of our images are still read by radiologists, but you may see in your report, it'll say no evidence of pulmonary embolism as determined by artificial intelligence. I can't speak to what Sinai's policy is and how they're incorporating AI, but that is certainly something that is kind of a hot topic right now.
Yeah, I mean, I have a lot of concerns about issues with how things are read, because I've had times when the doctor has found something when they've seen it that was not picked up by the
Yeah.
radiologist. So that's already
Yeah.
a concern. Now we have machinery that's coming in. I'm glad you brought it up. I mean, I'm not happy to hear it, but I'm glad to know that it's going on. So thank you for bringing that up.
Yeah.
Thank you.
Of course. Okay. All right, we'll go ahead to the next slide. So MRI. MRI stands for magnetic resonance imaging, and it uses magnets to produce 3D images. MRIs do not involve radiation exposure. They are a bit more expensive, and if you have a metallic implant, unfortunately, you may not be able to get an MRI just because of the magnetic field. They're used commonly for soft tissue, like I had mentioned. So soft tissue organs in the body include your brain, spinal cord, nerves, muscle tissue, and tendons, ligaments, specifically in GYN. It includes your uterus, ovaries, and vagina. It uses a contrast called gadolinium, and it's much more less common to have a reaction to this versus the CT scan contrast. Again, with your kidneys, it's important that, we look at them. It's not as damaging to the kidneys as, the iodine contrast can be, but for patients who have dialysis, like this may not be an appropriate method. We will sometimes order this with something called vaginal gel. If you have a vaginal mass or a fistula that we're concerned about, we need to get a better picture. We'll order an MRI with vaginal gel, which gives a more enhanced picture of the vagina. I don't know if you guys have had an MRI before, but it can be a bit claustrophobic. You kind of go into a small tube. And so if that is something that's concerning to you, please let us know, because we can send you outside of Mount Sinai for an open MRI. I believe there's a couple locations throughout the 5 boroughs that don't involve you getting into that little tube and then sitting there for all the images. But you can see here, this is a picture of a fibroid actually. So see how this compares to the CT scan, where there's much more definition here. You can still see borders and you can see the, the bone of the spine here, but you have a lot more definition to the actual soft tissue. The right picture here is a normal uterus. And then this is a uterus with a fibroid towards the back of it. So a lot of the times if patients come, I work with Dr. Koloff, who has a really big surgical practice, and he does a lot of benign surgeries in addition to his gynecologic oncology surgeries. And so we'll see a lot of patients with fibroids, heavy bleeding, and we'll send them for MRIs. And these MRIs are really good to help him look at the uterus, see where these fibroids are, and then see if surgery is feasible or not. And if surgery is feasible, then what kind of surgery? And like I mentioned before, an MRI may be a good counterpart to your other workup with a CT scan or a PET scan, because it gives us a better look at the soft tissue. If you have a mass on your cervix, the MRI is going to give us a really detailed view of how big that mass is, where it is exactly, is it going into the rectum or the bladder, and helps us kind of get a really in-depth staging of that. And so, yeah, that is an MRI. Any questions on MRIs? All right, moving on, we'll do PET scan. PET stands for positron emission tomography, and it measures the amount of metabolic energy of a tissue. If your tissue is highly metabolic, or it has a high what we call FDG activity, we may have a high suspicion that that tissue is cancerous. But there are some tissues that do have high activity at baseline. You're always going to see urine, your bladder's always going to light up on a PET scan. Sometimes your brain can have a highly FDG avid activity too. And so we have to take that into consideration when we do these scans. We often order PET scans in combination with a CT scan for cancer detection, staging, and response to treatment. And we almost always use a PET scan in cervical cancer workup. PET scans are really good in helping us rule out distant mets, being metastases, and it does also include radiation exposure. You do get injected with an IV radio tracer, and that helps produce the images of the highly metabolic tissue. Basically, that radio tracer will interact with highly multiplying cells, and it will create these, what we call FDG avid images. So you can see here, this is just an image I found off Google, of primary cervical cancer. But you can see how bright these areas are here in the pelvis. And then further up, you can see here these other little bright areas. So this is what they're saying is the primary cervical cancer. With then you see this little spot here, which is then correlated to the lower image. That is a metastatic lymph node. And so these scans are really helpful when we send you to radiation. So radiation knows exactly what to include in their treatment field. You'll also see here, this patient's brain is obviously bright yellow. That's just because brains are highly metabolic. That wouldn't be, a brain metastases because the whole thing is lit up. But when we're doing PET scans, it's obviously very important that we determine the normal anatomy from something that's abnormal. And so your doctor won't always order a PET scan, but if you do have a cancer that was shown on a PET scan and nothing else, then that's something that we'll continue to follow you with. And so, PET scans are very important to part of the workup. And like I said, they're almost always, I don't know why, I don't know a patient with cervical cancer that we've never ordered a PET scan on. So that's what we most commonly use, but we do use it in the other cancers too, especially when we're ruling out other areas of possible cancer spread in the body. Any questions?
I have a question, and maybe I just missed it. Why is it that cervical cancer that you use a PET more?
So in cervical cancer, we use a PET more because we stage you first clinically, meaning we don't always jump to surgery with cervical cancer. The reason being is that, first of all, the whole point of surgery or treatment is to give patients the longest possible interval or cure before the cancer comes back. If it's not curable, the first point is cure. If it's not curable, then we want to give you the longest amount of time before your cancer would potentially recur. And all of the years of studies that we've had in gynonc, they basically show or they'll show like what treatment works the best. And so for cervical cancer, we know that like if we just jump to surgery, not always going to work the best. So we'll do PET scans to evaluate the extent of disease, mainly the lymph nodes, to see if, you know, if it's caught very early and there's no lymph node involvement, then maybe this patient just needs surgery and not radiation. If they do need, you know, if they meet the criteria and they get surgery, that's fine. We'll evaluate the lymph nodes in surgery. But if the cancer is, if the tumor is too big and the cancer is a higher stage, then patients typically go to chemo and radiation first. And the radiation field needs to know if the lymph nodes are active or not, because radiation is another local treatment, right? Radiation's not chemo. Chemo goes to everywhere throughout the body. Radiation only acts in the specific field that's being treated. So we need to know if there are lymph nodes in the pelvis that need to be included in the radiation field. And so that's why PET scans are really important in cervical cancer. Cervical cancer is the only stage that we, or is the only cancer that we stage clinically still as well, meaning we don't always do surgery to stage these patients up front.
Thank you.
That was a good question.
Glenn, your hand is up.
Yeah, I have a question about the preparation for the PET scan. I've been told that I'm not allowed to exercise. I never knew exactly what exercise meant. Does it mean walking, or does it mean like going on an elliptical? And in some instructions for PET scan, I've seen that, you know, people are asked to lower their ingestion of carbohydrates for 24 hours before. So are those things really necessary, especially the exercise part?
I think they're just trying to avoid any kind of confounding results that we might get from exercise, or your body working, you know, over time, maybe from ingesting carbohydrates or exercise, or like or more rigorous exercise. That might cause some, my guess is just more, your tissues might be more active after those activities, which might produce some, might highlight some things on the PET scan that we might not want to see. I can't really comment on how important that is or not, because I do think you need to be fasting too before a PET scan, but usually the radiology team will review all of that with you before a scan. I think that the biggest thing is that we don't want any confounding results that might, anything that might obscure what the true, you know, the true things that we're looking for versus what's a normal function of the body that also might show these, some metabolic, you know, reactions going on.
Well, does just normal walking itself cause kind of metabolic activity?
I mean, I think anything probably could, but then, you know, breathing, you know what I'm saying? I don't, walking, that would be something that you would have to confirm with you know, your radiology team, but I can't imagine walking would be too aggressive.
Said no. Anyway.
If there is a very highly aggressive cancer that we're looking at on a PET scan, we're going to find it regardless. If you go on a 30-minute walk beforehand or not. I think they just want you to do everything possible to like prevent any other things from coming up on a PET that might obscure how your doctor interprets the results.
Okay, thank you.
Yeah.
Hi, I have a question. Sorry, my reactions thing is not working to raise my hand. But just a quick question. So in regards to the PET scans, I have stage 4 endometrial cancer and it's a recurrence. And so typically, and I'm also treated at Mount Sinai, with the exception of one time, I've only had CT scans. I've only had CT scans, with the exception of one time last year. And so I was just wondering, is it just not as common with endometrial cancer? And I'm sorry, I apologize if you answered this earlier. I joined a little bit late. Or is it?
Oh, no, that's fine.
Yeah.
So, I'm not sure at what point they got the PET scan in your treatment, but if they've been following, typically we won't always get PET scans for endometrial cancer or ovarian cancer. We do sometimes, but there's a specific reason typically. And when you're recurrent, you will most likely start chemo. And we know that when you get the chemo, it's going to target most of the tissues within the body. And so, you know, it's good for us to know where your recurrences are and for for restaging, but typically we can see that with a CT scan, which includes the chest, abdomen, pelvis. Now, if your doctor was ever concerned that it spread to like your brain or your spinal cord or, you know, somewhere else, then at that point they may order a PET scan just to double check, or some other, like a brain scan or something else. But typically we can get everything that we need from a CT scan. There are just these other, these other times where the CT scan's not clear, or we think something else might be going on, or say a patient had some really aggressive symptoms, and we might be more inclined to add a PET scan to those other images.
Okay, thank you so much.
You're welcome.
What's the difference between the PET scan and the CT scan?
So the PET scan, see how it has this like this colorful picture here. It's going to show, like it shows not just the outline of an image, but it shows how fast the cells are reproducing of a tissue. And usually cancer cells reproduce very, very quickly. It's what we call highly metabolic, but they're reproducing, they're growing, they're like very, very active. And the PET scan contrast will measure how active those cells are. And so when we see something on a PET scan that's this bright color, it's more concerning, that's like a highly, highly active tissue. And if that's not in an area where it's supposed to be, like the bladder or the brain, then it's pretty suspicious for cancer at that point. And that's how, for some patients' cancers, we track it, because it may not show on a CT scan or an MRI, and maybe it only shows up on a PET scan. So it's just measuring different things. The CT scan is going to measure, the size, the shape. It'll show you a picture of it. This will measure how actively dividing the cells are, how fast it's growing, or how metabolic it is. Hopefully that makes a little more sense.
Thank you so much.
You're welcome.
Mallory, this is Heidi Katz. Hi there, Oncology Social.
Hi.
Question about sensitivity. Are any of these particular tests more sensitive than another, so to speak?
I think it depends on the cancer. So like and it depends on what you're looking at. So obviously the PET scan is going to be more sensitive to the metabolism, I guess how FDG avid it is, because that's what we're measuring. MRIs are usually very sensitive. They're going to pick up on a lot of things, but they're not specific, meaning you can have a breast MRI done, and it's going to show a lot of stuff, but it's not going to tell you exactly what that stuff means. It just shows that you have it may be very sensitive in picking up a mass, but it may not be specific in detailing what that mass is. And so when we'll get ultrasounds, ultrasounds can be, I don't know what the degree of sensitivity is, but we'll get an ultrasound and it might show a mass, but it doesn't tell us what it is, right? It just shows a mass. It may give some, detail regarding if it's complex or if it's simple. But then what we'll typically do is order a CT scan or an MRI to get a better picture. And one thing I tell patients is that, yes, we have this image, but it doesn't tell us what it is. We don't know what it is because nothing's 100% specific until we put it under the microscope and that mass is removed. And so there are, I think, just varying degrees of sensitivities between these different images. But again, a lot of the times it comes down to your doctor and how good they are at reading these scans, and how their expertise and all the years that they've been in practice have, can really tell you what they think. Because them looking at the images is I can't say it again, but it's so important that your doctors look at the images and tell you what they think. We have some great radiologists here at Sinai, but people are human and they can miss things. So it's always good. It's always good to have your doctor look at the images as well.
Thank you. Thank you.
There's a question in the chat, and the person wrote, when I get a PET scan, I have to fast and they check my sugar levels before they even inject the radioactive tracer. Is that just because I'm pre-diabetic, or is that common practice?
Sorry, guys, can you hear me now?
Yeah.
Okay, great. I'm so sorry. Okay, what was the question again?
Someone is sugar is checked before getting scans, and wondering if that is because she's pre-diabetic, or is that typical?
It might be because you're pre-diabetic. If you're taking anything for diabetes that they want you to also hold before the scan, that might be a reason why they are checking it too. But most people have to fast before CT scans. And sometimes I may be making this up, but I'm pretty sure you have to hold metformin too before PET scans.
While we're back to the CT
correct.
scan, actually I have a question. In one of our groups yesterday, someone asked, they had a CAT scan 3 days prior, and she was experiencing some dizziness. She had spoken with her doctor, she had a brain scan, she was doing all the correct things as a patient, but was looking towards her peers to see if anyone else had experienced that. Is that something that has been seen? Everyone else in the group had never experienced that before, but just having this opportunity to ask you, I'm wondering if that is something that's potentially a symptom of a CAT scan, of a CT scan.
The CT scan contrast can interact with some medications too, so I'm wondering if she had medication interaction or a slight interaction that maybe enhanced.
She's not here now, but I figured I would ask for her.
Of something, and then the dizziness was secondary to that.
Thank you.
But yeah, you can, patients can get reactions day of. I've seen it with chemo, that patients have reactions a couple days later where they are very flushed, their face is swollen, they're feeling a bit dizzy. So it's hard to say, but maybe it could have been the contrast, sure. But typically with contrast reactions, we see it within 15 minutes or so. And it's, the classic facial swelling, shortness of breath, chest pain. Sometimes patients just get hives and that's it. But we do take the reactions really seriously. And if there's anything indicated in the chart about a reaction and we didn't pre-medicate the patient, then radiology is always going to call us and, say your patient needs to come back for another scan once they've been pre-medicated, because they obviously want to avoid any kind of severe reaction in the control room.
Sean, I believe that's probably what you were about to say when we both spoke at the same time. I see your note in the chat is that it's correct, no metformin before or after scan.
Yes, and they push you to drink a lot of water to get it out of your system. I'm saying yes because I'm a diabetic, and that's what they always told me, not to take it the night before and not to take it like a day after.
And yeah, because it can stay in your system and they can react. And for any patients that do want fluid after your CT scan just to flush it out, if you have some kidney issues, you could always ask your doctor to set you up for that.
Someone sent me a private message. They wrote, I have ovarian. Should we get a mix of CT, MRI, and PET scans to check on any possible issues at different time periods?
So typically we will order you may need all of those things ordered in the diagnostic workup so we can get a better understanding of what exactly we're treating. But once we get the tissue, it's under the microscope and we have a definitive diagnosis, your doctor may only choose one modality to kind of follow you with. And part of that comes down to, the CT scan is the best thing that we're going to use. Because if you have a recurrence, it's typically something that's solid and that's picked up on your CT scans. But an MRI, it might be part of your diagnostic workup where we're getting, you know, we see a mass on the ovary, but we want more detail of like the actual ovarian tissue. And that might be part of that process. And once we know that it's ovarian cancer, we may just stick with the CT scans because we're tracking these target lesions. Another thing is that insurance probably won't approve all three of those things once we have an established diagnosis and we're following with one of them. You know, I realized that I didn't finish my slideshow. So let me just share my screen again real quick. Slide. Okay, let me go to results. Okay, important. Do not attempt to interpret results on your own. Like I said, they'll post to my chart as soon as they are ready. You might see that they've been read by a radiologist. They may have been read by AI, but your doctor may not have seen them yet. And so a lot of the times you may be the first person as part of your team that's actually seeing the results. And I know it can be scary. This is like a state mandated thing. So unless you you specifically tell your doctor, like, this causes me a lot of anxiety, I don't want to get my results posted until you've reviewed them. Unless you say that to your doctor, they're automatically going to go to you first in your MyChart. I think it's a great practice to make a follow-up appointment with your doctor as soon as you know when your CT scan is scheduled, so you have a time and a place to discuss the report with them. That also ensures that they've already looked at your images, and, you know, if you don't have that set up and you're sending a MyChart message and your doctor's in surgery or they're not available, you know, you'll get the NP, you'll maybe get somebody on the clinical team like the nurse, and they can, you know, use the report and interpret what they can, but it's not the same thing as your doctor looking at the images and, you know, saying definitively, you know, I've reviewed this and this is what I think. Again, sometimes the radiologist will comment on something and the doctor doesn't agree with it. Or sometimes the radiologist might miss a target lesion, which is an area that we've been looking at over your past 3 scans, and we're measuring it and we're trying to see if it's growing or if it's shrinking. And these areas need to be compared during your treatments to monitor response. A lot of the time we recommend that you get your CT scan done within the same institution, and MRI, PET scan, whatever your imaging is, done in the same institution, so that the radiologist reading it can compare your current scan to your previous one, so we can measure these target lesions. Again, if you don't want your report to go to your MyChart automatically, just let your team know, and all we have to do is click a button. But legally, we can't do that without your blessing. So I wasn't sure if everybody was aware of that option, but it does exist. The next page I have is just a list of all of our radiology departments. I don't know if you guys want to take a picture of this. But it has the hospital, the location, and the phone number for scheduling. So as long as you get something done within Mount Sinai, we should be able to access all of the images. I know some patients prefer to go to one specific spot, but as of today, these are the different facilities within Sinai where you can get your imaging done. Now, you can't get like MRIs done all of these places. So if you want to go somewhere for a certain scan, you may have to call ahead. But I can tell you here at Chelsea, we can do MRIs, we can do PET scans, we can do CT scans, we can do mammograms, we can do ultrasounds, we can do bone density scans. We're pretty comprehensive, which is great.
Yeah. Thank you.